Here we present a case of customized BS inlay with 3D geometry mapping in a case of keratoconus. Corneal collagen cross-linking is the current gold standard in the treatment of keratoconus. However, it has some challenges in the cases with low pachymetry and high keratometry. Literature has reported Bowman layer transplantation as a modality for the treatment of keratoconus. Exclusive Bowman layer transplantation is surgically very challenging and it has various complications like Bowman layer tear and irregular graft thickness. We have already published a simple and safe technique of Bowman stromal inlay using IOL injector for the management of advanced keratoconus, which showed stabilization of keratoconus and overall increase in pachymetry. We have also reported a case of 10-year-old boy where we showed that Bowman stromal inlay is an effective alternative to cross-linking, but we could not find any significant change in keratometry and thus visual acuity. So we thought, can we change the power of the lenticule to be transplanted? Barker et al. In 1949 for the first time described intracorneal inclusion of a lenticule to modify the refraction of the eye, and they concluded that modification of the refraction is in relation to the power of the lenticule and its location in the thickness of corneal parenchyma. So with the aim of stabilization of keratoconus and to increase the refractive outcomes, we tried to create a reverse geometry in inlay according to the interior geometry of patient's cornea. So here we present a case of 21-year-old male who presented with complaints of gradual painless diminution of vision since 5 years in right eye more than left eye. Best corrected visual acuity was 6 by 18 in right eye and 612 in left eye. This was the tomography of right eye, which shows thinnest pachymetry of 434 micron and steepest keratometry of 55 diopters. So this patient was taken up for customized BS inlay with 3D geometry mapping. The surgery incorporated 4 steps. First, the Bowman stromal inlay was prepared using femtosecond laser. Then the customization of the inlay was done according to the topographic data of the patient. Then this customized inlay was transplanted into the intrastromal pocket of the recipient using IL injector. So first let's have a look at donor preparation. First of all, the tissue was carefully mounted on the artificial anterior chamber. The pressure was kept a little on the tighter side. Epithelium was removed with the aid of alcohol, ensuring complete epithelial removal. Then the limbus was marked using gentian violet marker. After proper docking and centration, femtosecond laser was fired, which created a Bowman stromal inlay of 170 micron thickness. Then the edges of the lenticule were lifted 360 degrees. The lenticule was then lifted up and flipped to have the stromal side up. Then the excimer laser was fired on the stromal side of the lenticule. Then the marking was done at 9 and 12 o'clock in the inlay to ensure correct placement in the stromal pocket of the patient. Then the lenticule was preserved in BSS. So the next step is the recipient preparation. Creation of the intrastromal pocket was done using femtosecond laser at a depth of 130 microns. In this, the energy of the side cuts was reduced to minimum. Now let's have a look at BS inlay transplantation. First, pilocarpine was injected to constrict the pupil and mark the center of the cornea. Then first the canal and then the intrastromal pocket was opened up using lamellar dissectors. Now the lenticule was loaded in the cartridge of IL injector with stromal side up. The lenticule was then gently inserted in the intrastromal pocket. The lenticule was then unfolded and adjusted according to the markings present for correct orientation. This is the post-op picture of the patient at 3 months with the best corrected visual acuity of 6.9. Pentagram map at 3 months shows thinnest pachymetry of 529 and the steep K of 53.5. Thank you for watching.